Hello and welcome everyone to another Saturday radiology session. My name is Dr. Amar Udare, and this session is brought to you by Team Radio Gyan. We do these sessions every Saturday at 8 p.m. India Standard Time and 10:30 a.m. Eastern Standard Time. What we're going to do in the next 30 minutes or so is we'll be discussing a few interesting cases. I'll be discussing these on a PACS-based format. I'll be scrolling through images, and you can shout out your answers in the comments section. These are routine cases that you'll encounter in daily life. So some of them can be exam cases as well, and I'll discuss important points as we go through these cases. So good morning. We have Nancy from Taiwan, Selda from Turkey, and Jamila from Oman. Let's go start sharing our cases. So the first case, let me. So this was the first case. I shared this one in our Telegram and WhatsApp radiology groups before we started this session. So for those who saw this case earlier, can start typing their answers. For those who are not yet joined in our Telegram and WhatsApp groups, I leave a link to those in the description. You can join those. We discussed interesting radiology cases, and I share useful resources whenever I come across those. So this is your first case. So this patient presented with the, so this patient was in the ICU. They had a myocardial infarction a few days ago. So that's a clue to the diagnosis. I'll go over the images. If anybody spots anything abnormal, you can let me know in the chat, and I can go over the findings. So that's the actual CT. I'll scroll once more. Okay, so let's pull up the coronal CT as well. This may be helpful. So that's the coronal CT. These cases, I completely understand, because it may be difficult diagnosing while I'm scrolling these. So it's okay if you don't get these. In exams, obviously, you'll have a complete set or a classic single image. So let's, let me see. Yeah, this is the coronal in full screen. Okay, excellent, Selda. You've picked up the finding. So there's, as you mentioned, there is less enhancement and bowel wall thickening. Intramural gas in the stomach. Let me see. So probably that's in the stomach lumen. This can be seen often. So that's incidental and of no clinical significance. That's probably inside the stomach. So Sharmila, that's not in the bowel wall. Nancy, correct. That's a good thought. So as Selda mentioned, so you see these bowel loops in the left half of the abdomen. So especially large bowel loops in this region, they show wall thickening and they hardly show any enhancement. So let's look. So whenever you're reading body CTs, abdominal CTs always have a system. So you can have you can have your own system. But typically, the easiest way to go about reading a body CT is going from top to bottom. So look at the lung bases, look at the liver, look at the hepatobiliary system. So liver, pancreas, gallbladder. Then maybe you can look at the adrenals, the kidneys, the bowel, then the pelvic organs. And finally, the mesentery, peritoneum, and bones, and say the peripheral areas. So when we look at bowel here, I usually start looking at starting from the esophagus. So is there a hernia? Is there some fluid going into the esophagus? So in this case, you do see some fluid. So there's probably some reflux. Then I look at the duodenum, which is normal in most cases, but sometimes you may see a diverticulum here. Then comes the small bowel, jejunum, and ileum. In this case, you see the small bowel wall enhancement is quite, it enhances quite well. Even the proximal large bowel shows decent mucosal enhancement. And for comparison, I'll show you this, this image here. See, look at the enhancement of the mucosa of the ascending colon versus the descending colon. There's hardly any enhancement in the descending colon. And look at the fat. So that suggests that there's something going wrong in the descending colon. So, and especially look at the wall here. It's paper thin and it's barely perceptible at the level of the splenic flexure. You go more inferiorly, trace the bowel loop here. It's similar, pretty bad enhancement. In the region of the sigmoid colon, you also see some thickening. So as all of you have rightly mentioned, there is so this is a case of ischemic colitis. So let's go a step further. Can anybody think of a particular pathology that could have caused this kind of distribution of ischemic colitis, depending on what area of the bowel is involved? What could have been the pathophysiology? So mesenteric ischemia is of 3 types. Acute mesenteric ischemia, it can be arterial, it can be venous, or it can be mixed type. And there's a 4th type, afibrillation. That's a good thought because that can cause the thrombosis and then can occlude distal vessels. So that's a very good thought. So inferior mesenteric artery, probably. So the history that I gave in this case, so this patient has a myocardial infarction. So think about think on those lines. So what kind of ischemic colitis you may see in those cases. So this this region of the bowel, is there anything particular about this? Atherosclerosis, yes, that's definitely a clue towards the cause. The most common type of acute mesenteric ischemia is arterial. So whenever you see bowel ischemia, go back and look at your main vessel. So in this case, let's look at the SMA and IMA. So the SMA here, there is a plaque sitting here, but the major branches look patent. Let's look at the IMA. So the IMA, even the IMA and its branches, although they're very small, but I don't see a frank thrombus in this case. So this is non-occlusive mesenteric ischemia. So excellent, Zelda, you've rightly pointed out. So whenever there are, say, low cardiac output states or any cause that can cause mesenteric vasospasm, that can give rise to non-occlusive mesenteric ischemia. And this is a very particular location for that because of this being a watershed territory. So let's look at the coronal. This portion of the bowel in the, say, right half, let me put out like start annotations. So give me a sec here. Okay. So this portion of the bowel is supplied by the superior mesenteric artery, and this portion is supplied by the inferior mesenteric artery. So this area, the region of the splenic flexure, that is what is known as watershed territory. So non-occlusive mesenteric ischemia, just like infarcts in the brain, you see them at the at the junction of the gray-white matter because that's a watershed territory. So remember, this is also a watershed territory in the abdomen and a common site for non-occlusive mesenteric ischemia because it's a watershed zone. So that was a case of non-occlusive mesenteric ischemia. The causes are myocardial infarction. Post cardiac surgeries is also an important cause. We have seen a few cases where these patients undergo cardiac surgeries and then they present with this. Any low flow output state can also give rise to non-occlusive mesenteric ischemia. So that was the first case. Excellent, all of you who got it right. So stranding of fat localizes. I'm not sure about your question. Maybe you can reframe it and I'll take it later. So Ram Kumar Varma, that's non-occlusive mesenteric ischemia, also known as NOMI or NOMI. That's absolutely correct. So let's move on to the next case. So that's our second case. So this patient was a young patient, a 10-year-old boy who was presenting with a swelling in the forehead region. Let's go over the images, and if you spot anything abnormal, please let me know, and I can go over those images again. Let me increase. Yeah, it's better now. So the brain parenchyma looks pretty okay. Does anybody spot anything abnormal that needs attention? Superior sagittal sinus thrombosis, Vijay, that's a good thought, but I have been fooled before. Like this appearance of the superior sagittal thrombus can be seen in asymptomatic, like this is in most cases not very significant. You need to see it really dense. So this is not as dense as I would expect in the case of superior sagittal thrombosis, but that's a good thought. When you see hyperdense superior sagittal sinus, that can be picked up on non-contrast CT. So remember the history that I gave you. This patient presented with frontal swelling. So this, I'll pause at the image of interest. Sinus pericranii, that's a good thought. Again, we're looking at significant findings. Okay, so this is the area of interest. Does anybody pick anything abnormal? Pneumocephalus, again, let me adjust the window for you. So whenever you're suspecting, say, air of any kind in any body organ, just turn it to lung windows. If you don't see it on lung windows, you can put an ROI. That's, again, easy, but lung windows are excellent for picking up air. So let's go over and see if there is any pneumocephalus here. So there is none. So probably it was just extraaxial fat that was simulating simulating pneumocephalus. Okay, so that's the image of significance. Scalp hematoma, excellent. That's at least you have picked up the abnormality here. So what we are looking at, so this patient did not have any history. So scalp hematoma, so I guess you're pointing to this abnormality in the left frontal region. There's another finding here which makes us think that this is less likely to be a scalp hematoma, cortical destruction of inner table. So Selda, you've rightly pointed out. So the point that I wanted to drive home in these cases is that always, like whenever you get a CT brain case, don't forget to look at the subcutaneous tissues, scalp, and the bone windows before you sign up your report. So here we do pick up some cortical irregularity in this region. Okay, oops. Cortical irregularity, there is this swelling here. So as few of you have rightly pointed out, left subfrontal subgalean. So if this patient had a history of trauma, this would be very typical for that, and we should end it there. But when you see cortical destruction, and that would be very unlikely for a subgaleal hematoma. You should be thinking of more of lies of soft tissue lesions. So let's look at the bone windows and how this lesion is seen on bone windows. So that's the bone window. Okay, so would you still stick to hematoma, or would you like to change your diagnosis? Hemangioma, that's a good thought. Vascular malformation, that's a great thought. Okay, so a couple of thoughts here. Epidural mass, unlikely. So this mass is centered centered on the bone. So let's start thinking about bony pathologies. Hemangioma is a good thought, but I have not seen hemangiomas cause this much destruction. The ones that I have seen, this is small and they're restricted. They are confined to the bone. This patient has a destructive lesion with soft tissue, so hemangioma would be lower down. Nancy has said Langerhans cell histiocytosis, and that's what this was. When there is isolated skull involvement, what is the preferred terminology for this? Excellent. So all of you have got this one. So Ram Kumar Verma, METs again is a good thought, but in a pediatric patient, METs would be lower down. There's one pathology which can cause skull mets. You can mention that in the skull mets in pediatric patients. You can mention that in the chat. So LCH or plasmacytoma, again, a younger patient, you would not put that as a differential. Sutural mets, again, that's a good thought, but I would have given you a history in that case. Eosinophilic granuloma, yeah, that's what the term I was looking for. So that's what this turned out to be. This patient was okay, so these are images that we took later. Does anybody know what these are? So our differentials were like similar, eosinophilic granuloma or some kind of infection. Hemangiopericytoma is also a good thought. But again, common things should be top of our differential. So does anybody know what these things are on the skull tomogram? What's happening here? Beveled edges, yeah, that's very typical for eosinophilic granuloma. I'll explain what beveled edges means when we follow it with the on our discussion. So Awad has rightly pointed out in a pediatric patient, if you see multiple aggressive skeletal lesions, neuroblastoma mets should be on top of your differentials. Excellent. What's happening here? So these are for stereotactic brain biopsy. So these are the markers for that. So this patient underwent a biopsy. This was a scan, I think, a few months later, and you see the lesion has grown as compared to before. Let me put some bone windows here. Yeah, so the beveled edges, as has been typically described for eosinophilic granuloma. So this is what the beveled edges mean. So this kind of edge is not like, this is what a beveled edge is. So if there is a surface like this with edges like this, so this is what beveling means. So eosinophilic granuloma has this typical beveled edges that have been described. So sometimes we definitely learn the typical appearance, but we don't know what exactly it means. So wherever you come across something you don't understand, make sure that you Google it out and understand it so that you have better memory and you basically understand the pathology well. So these are beveled edges of eosinophilic granuloma. Sometimes you may see a sequestrum of dead bone, which is known as button sequestrum. It's characteristic for like it's been one of the differential for that is eosinophilic granuloma. So this was a case of eosinophilic granuloma. And the point that I wanted to drive home was make sure that whenever you look at your CT brain images, you don't forget the corners, which includes the scalp and the skull. And even let me just go through what else can you visualize on a CT brain. So let's go to brain window. So often all of you as say residents or even radiologists, you'll report a tons of like CT brains for say acute weakness or stroke or other pathologies. Incidentally, there may be a lot of findings in the peripheral areas. So what peripheral areas you need to look at whenever you look at CT brains? So look at the parotids, the skull base, look at the foramina, the vessels, and the symmetry of the neck spaces. All of you almost always look at the orbits in PNS. Most of you have that in your template, but make sure that you look at the parapharyngeal fat pads. Are they symmetric? Are they pushed on either side? Look at the mastoids. Although the study may not be a dedicated mastoid study, but a temporal bone study, but you may pick up a lot of incidental findings. So make sure that you look at these peripheral areas of your CT brain when you report these. That was that case. Excellent. Diagnostic, like most of you picked up that once I showed you the bone window. Let's look at the next case. Okay, so this was the case that I think I shared it on our Facebook group. This patient presented with left-sided upper abdominal pain. I have, I think, non-contrast and arterial images for you. So left upper quadrant pain. This is the non-contrast CT. So the liver looks fine. There are some calcified splenic granulomas. I think this is probably a more delayed phase. or what must have happened is that the technician must have given a small amount of contrast, which is excreted through the kidneys. So kind of a non-contrast study, but there is some contrast in the collecting system. Osteomyelitis, yes, for Ram, for the previous case, we did think of that as a differential. That's the reason why the patient underwent a biopsy, and it turned out to be an eosinophilic granuloma. Okay, apologies for this, because the contrast in the collecting system makes it a bit difficult to diagnose the pathology. But so this is the representative image. So what we see here is the left kidney is enlarged, and there is this low density soft tissue in the collecting system. In fact, some of it is going, there is breach of the capsule, and it's going posteriorly to involve the left psoas muscle. Unfortunately, I don't have images below, but yeah, I was tracking along the left psoas muscle. So a couple of thoughts that should come to your mind. The first thing should be, is it an abscess? So unfortunately, this patient did not have, say, acute symptoms. Again, still an abscess cannot be completely ruled out, but that was one thought. This patient additionally had a calculus sitting at the renal pelvis. It's difficult to recognize it here, but I'll give you that history. So given the presence of a pelvic obstructive calculus and lower density soft tissue in the renal collecting system, what differential or what diagnosis you should be thinking of? So bare paw sign, Anil says, yeah, bare paw is sign and xanthogranulomatous pyelonephritis. So that's what this was. Left kidney, bare paw sign, Sharmila, Minu, Anil, Arbaz, Jamila, and I think all of you have got this one correct. So this was a case of xanthogranulomatous pyelonephritis. Typical imaging appearance would be as I described, as pelvic obstructive calculus and low density soft tissue filling up the renal collecting system. Remember that there are cases which have been described of extrarenal or perirenal xanthogranulomatous pyelonephritis as well. So this is a low-grade chronic inflammation of the kidney. So bare paw sign. So the obstructing calculus and the dilated renal pelvis that gives rise to appearance similar to that of a bear's paw. So like this, the dilated appearance. Apologies for my drawing. So this is what gives rise to the bare paw. You can just Google it later, and that's why it's called bare paw appearance. So excellent. All of you got this one correct. A pretty straightforward case. Let's look at our fourth case. So this patient had lung cancer, and incidentally, they found a adrenal lesion. And so this CT was done for further evaluation of the adrenal lesion. Remember, adrenal lesions are very common in in the general population, and in lung cancer patient, adrenals would be one of the most common site of MET. So whenever you're reporting a lung cancer CT, make sure you comment about the adrenals, because if the patient has METs, that'll make the disease, that'll upscale the disease, and you'll cover adrenals in most of your CT thorax studies. So this is the pre-contrast T1 fat sat image. Let's look at the key sequence. So whenever you are doing an MR for further evaluation of a adrenal lesion, what are the key sequences that you'll be looking at? Histoplasmosis. Okay, that's a good thought, but I'll show you all the image sets, and maybe that'll help you better diagnose this condition. Okay, so when you're reporting, say, MRs for adrenal lesions, what is the one sequence that you need to look at? The key sequence. Yeah, excellent. So Selda and Jishan have rightly pointed out. So in phase and out phase sequences, these help us to distinguish if the lesion has intracytoplasmic or microscopic fat. If the lesion has macroscopic fat, that will be a myelolipoma. Remember, this is a common mistake that a lot of, say, even radiologists, residents and radiologists do. On a CT, if you're looking at an adrenal lesion with obvious fat, so the density matches that of subcutaneous fat, that is not an adenoma. That's an adrenal myelolipoma. Although it doesn't make a big difference, in both of these are benign conditions, and nothing needs to be done about that, but you need to understand the pathology better. So fat, macroscopic fat in adrenal lesion is myelolipoma. Microscopic fat is adrenal adenoma. Now, because an adenoma has microscopic fat, you won't be able to see it on CT. So on CT, you will see an adrenal lesion with low attenuation, which will not match that of the skin or subcutaneous soft tissue. The Hounsfield value for that will be from -10 to 10. So any lesion with a Hounsfield value of, say, less than 10, but more than -10, that is suggestive of an adrenal adenoma. Now, when the lesion, the attenuation goes more than 10, that makes things difficult. Then is where you need to do other things to confirm the pathology, especially if there is a known METs. If the patient does not have a known primary pathology, you can be rest assured that this is probably an incidental adrenal adenoma. In this case, the patient had lung cancer, so we had to do an MR. So on MR, how do you distinguish an adenoma versus a pathological lesion? So again, because adenomas have intracytoplasmic fat, they can be, we can diagnose that fat on in and out phase images. Okay, so these are in and out phase images. So which one of these is an in-phase image? Which one is an out-phase image? So let me know in the chat if you think the image on the left is the in-phase image. Which one is an out-phase image? Let's keep it simple. So is the image on the left the out-phase image, or the image on the right is the out-phase image? So type L or R respectively. Which of these is an out-phase image? So both of these are, say, T1 weighted sequences. Okay, Ivan has rightly pointed out the cause for why are we calling the right-sided image an out of phase or a post-phase image. So the one on the left, this one is an in-phase image, and the one on the right is the a post-phase or out-of-phase image. So you see this artifact around at the fat and water interface, or fat or organ interface. That is known as the India ink artifact. That is characteristic of opposed phase images. So this is in phase, this is opposed phase images. Now this is different, like these images are different from fat saturated images, because you see the fat, the macroscopic fat in the subcutaneous soft tissue, you're still able to see it. So these are different from your stir or fat saturated T1 images. So these are T1 weighted images, and they'll suppress and the intracytoplasmic fat will be suppressed on the opposed phase image. So let's look at this adrenal lesion now. So there's this right adrenal lesion of fairly significant size. Now, what would you call it? Is it concerning, or is it a benign finding? So that's T1 opposed and in-phase images at the level of the right adrenal. All of you have rightly pointed out, India ink artifact in the image on the right gives tells us that this is a opposed phased image. Excellent. So Zelda and Jishan you've rightly pointed out. So there is this right adrenal lesion, say maybe measures around a couple of centimeters or more. And on the opposed phase images, it gets suppressed. So most of it, there are a few areas that are not suppressed, but most of it gets suppressed. So this is suggestive of intracytoplasmic fat in a case of adrenal adenoma, and this doesn't need any further investigation. Another clue towards adrenal adenoma is the T2 appearance. In malignant cases, the T2 appearance is more heterogeneous. So this is the T2 study and look at the T2 appearance, it's quite homogeneous. If this was a metastasis, because inherently Mets are very aggressive, they'll undergo necrosis, hemorrhage, so the T2 appearance would be very characteristic. It'll be more heterogeneous than this. So that's another clue. In fact, we have written a paper on this, and quantitatively, you can distinguish adrenal Mets from T2, from adrenal Mets from adenomas. But again, that's quantitative studies. In routine practice, it's difficult to do those quantitative studies in all cases. By eyeballing, if the lesion is more homogeneous, you should be thinking on more lines of adrenal adenoma versus an Mets. Okay, so that was that case. Some adrenal adenomas, remember, are fat poor. In those cases, MR may not be helpful. So in those cases, what is useful is a dedicated CT adrenal study. So you do multiphasic CT of the adrenal gland, and depending on the washout characteristics, you can be able to tell whether it's an adenoma or an aggressive lesion. We have a dedicated section on adrenal imaging and the adrenal washout calculator. You can check it on the Radiogyan website. I'll leave a link maybe in the description for those who are who haven't checked it out yet. So that was about adrenal adenoma. Let's move on to the last case of the day. Okay, so this is an interesting case. I'll go over the images, and this is more of a regular routine case rather than a very like a typical exam case. This patient had a periampullary lesion, and they underwent PTBD a few weeks ago, 1 week ago, and then presented with right-sided chest pain. A radiograph and an ultrasound showed some effusion, and the CT was done following that. So let's go over the images. So the pre-operative, the pre-PTBD study did not have any effusion. So that's the PTBD stent. There's a tiny amount of gas in the gallbladder, which is probably secondary to the procedure. There's some fat stranding here as well. Again, I think all of this is secondary to the procedure. Subcapsular collection in the liver, Vidya, that's correct. We see this small collection in the subcapsular region. That's the first finding that we picked up, and we were wondering what was causing that. Is there like one of the stent holes open in this region? Did we not put the stent deep enough? There's another subcapsular collection more posterior-superiorly. Yeah, we were thinking on those lines. There's another finding, cholecystitis. Prakash, as we discussed, because this patient underwent a procedure, this is all probably secondary to just the procedure and unlikely to be acute cholecystitis. Right pleural effusion, that's a good thought. This patient, I'm not sure whether it was a female or male, but that's not relevant in this case. Good, that's a very good pickup, Selda. That's what I was looking at, and I found it abnormal. Like if you look at this diaphragm, it's quite thickened. Let me put up a pointer here. So the diaphragm here is quite thickened. Let's look at the diaphragm elsewhere. So maybe, yeah, let's look here. Usually you don't see the diaphragm this thickened. In fact, we have, say, an internal comparison here. Look at the diaphragm here, and the diaphragm here. There's significant thickening of the diaphragm in this region. So that's what I was like, that's the first thing that came to my mind. Why is the diaphragm that thickened? So I was wondering is it some kind of diaphragmatic infection or inflammation? But I was like, I couldn't think of a cause that could have caused that. Diaphragmatic rupture, that's a good thought. Vidya and Suraj. Selda, again, that's a very good thought. Is the stent passing through the diaphragm? And even Benny has rightly pointed out, is it iatrogenic diaphragmatic injury? Excellent. If you look to the chest to rule out LAM, okay, let's look at the chest. This patient didn't have LAM, but now that we have all the images, we can go over the lung findings. So probably you're thinking of, say, left side, say, chylous pleural effusion in a case of LAM. So no pleural effusion if female. Okay, got it. Why you were thinking of LAM? So this is not a case of LAM. Let's get back to what we were thinking earlier, and a few of you pointed out. Okay, so diaphragmatic injury. What cause of diaphragmatic injury would you think of in this patient? Diaphragmatic rupture. Difficult to call it a rupture because most of it looks intact. So this patient, I was clueless about what was happening. So I went to my IR colleagues and I discussed with them. And the moment I showed them this case, the first finding that they said that, oh, the left pleural effusion should not be here. The right pleural effusion should not be there. In fact, it was, I did not think about it. I thought that usually whenever we see any post-operative case, there's effusion. But that was a mistake on my part because this amount of effusion is pathological. So the first thing that they said, oh, this effusion is abnormal. Why is there this much effusion? And the next thing that they did was look at the coronal CT. Unfortunately, I don't have the coronal images, but then we went on to the note to read the notes. So this patient, the PTPD procedure, they had some difficulty entering the left system. So they had to put the tube on the right side, and the patient had difficulty holding their breath. So this patient had a pleural rupture. So the intercostal, the PTPD tube went through the pleura, and that's caused the pleural effusion and the diaphragmatic thickening and inflammation. So this was an iatrogenic pleural and diaphragmatic injury due to PTPD procedure, as all of you have rightly pointed. So I don't have the coronal CT, but let's draw an illustration. So sometimes the pleura can go deep in the intercostal recess. So whenever they do PTPD, they suggested that you have to think about, like, you have to be aware of this finding. So this is what happened. So this, let's imagine this to be the chest, this to be the diaphragm, and pleura is going deep below, and that's what they put in the tube here, and they inadvertently injured the pleura. So this was a diaphragmatic injury, diaphragmatic and pleural injury secondary to PTPD procedures. This is very rare. Only a couple of I could find only a few case reports. They said the incidence is around 0.5%, and the presence of right pleural effusion should be a clue towards that diagnosis. So excellent. Most of you were able to pick that up. Let's discuss and revise whatever cases we discussed today. So let me just pause sharing it here. So to pause share. So that's that. Present. And so yeah, the first case we discussed, okay, let me see. Okay, it's not sharing yet. Okay, now it should be sharing. So the first case we discussed was bowel ischemia. Bowel ischemia, most cases, the reason that it's important to recognize, okay, unfortunately, it's not showing up. Let me just see if I can share. Okay, there you go. Okay. Okay, so bowel ischemia, as we discussed, the reason that it's important to pick up because it has a very high mortality rate, and mainly because it's difficult to diagnose clinically, and even on imaging, you may miss it sometimes. Even I have been guilty of that as a resident, and even as a fellow, I have missed bowel ischemia. So now I make sure that I look at the images in the coronal plane and compare bowel enhancement. Jejunum is a good reference point, because in most cases, the jejunum will show excellent enhancement. It's very well perfused. So if you want to compare bowel enhancement, a jejunum can be a good internal control. In most cases, the pathology is arterial infarction, arterial occlusion, but rarely it can be due to venous ischemia or non-occlusive mesenteric ischemia, as we saw in our case. The findings on CT depends on what stage the infarction is. In the initial phases, you'll get bowel wall thickening, increased attenuation. If you do a non-contrast, that can be due to bowel wall hemorrhage. You can see filling defects in the vessels in cases of occlusive events. The other findings are, say, thinning of the bowel wall, and in final stages, there may be pneumatosis, that's air in the bowel wall, and portal venous gas, or even frank pneumoperitoneum. So depending on what stage the ischemia is, you can get different signs. This is an excellent article on radiographics, which talks about imaging appearances in different types of ischemias, acute mesenteric ischemias. You can go over this chart. If you later, you can point your cell phone towards this QR code, and that will point you to that article, or you can just Google it. Depending on the appearance, you can even point out, like you can even diagnose what kind of acute mesenteric ischemia it is. The next case we discussed was an eosinophilic granuloma. The typical imaging appearance, it would be of solitary or multiple punched out lesions with beveled edges. Commonly, these are seen in pediatric patients. So, and rarely you may see a button sequestrum, which is characteristic of eosinophilic granuloma. Again, here's a companion case to the xanthogranulomatous pyelonephritis case we discussed. What do you guys think of this case? So again, this patient had this occlusive, had this obstructive calculus in the pelvis, and there's all this fat and proliferation of fat in the renal sinus, and there's some stranding here. What would be your thoughts? So this patient had this condition for a long time. So this patient, so this is what is known as renal replacement lipomatosis, and it's commonly seen with xanthogranulomatous pyelonephritis. There is low density soft tissue that's proliferating in the renal sinus. It can be in the perirenal fat as well, and the common causes include chronic calculus disease, any form of chronic pyelonephritis, which is most commonly xanthogranulomatous pyelonephritis, and a differential in this case would be liposarcoma. But in the liposarcoma, it would be difficult to distinguish, but you can always compare it to the prior studies, and if there is any obvious soft tissue, then you should start thinking on those lines. So Girish, you've rightly pointed out, this was renal replacement lipomatosis. We discussed adrenal adenoma. So this is a nice flow chart from radiology assistant. Whenever you see an adrenal lesion, when it's less than 1 centimeter, you need not worry about it. If you have priors, you can compare, but usually less than 1 centimeter lesions are benign unless proven otherwise. So while less than 1 centimeter lesions, you can safely ignore. Now look at the CT image, and does it have any typically benign appearance? So what is a typically benign appearance? On CT, if the Hounsfield value is less than 10 HU, or there is signal drop on MR, that's an adrenal adenoma. If you see macroscopic fat, say the Hounsfield value is less than -10, or you can compare it with the subcutaneous fat and looks similar, then it's a myelolipoma. It's a water, like if it's just a water density lesion and homogeneous, then it would be an adrenal cyst. If you see coarse or curvilinear calcifications, then you start thinking of say benign pathologies again. If the lesion is more than 4 centimeter, it's worrisome. If there's no cancer history, consider biopsy, or you can do a PET CT just to see the HU value, the SUV value for that. For lesions that are 1 to 4 centimeter, that's indeterminate. In those cases, you may have to do further investigation. So if there is washout signal on MR, as we saw in our case, then that's an lipid poor adrenal adenoma. If there is no washout, then the pathologies include pheochromocytoma, adrenal cortical carcinoma, METS, and lipid poor adenoma. In this case, you may have to do a biopsy or an imaging follow-up. For pheochromocytomas, you can do biochemical studies. For adrenal cortical carcinomas, these are usually very large lesions at presentation. So the ones that I've seen are at least more than 6 centimeter. They're very heterogeneous. They'll have calcifications. So that is when you'll start thinking of adrenal cortical carcinoma. Pheochromocytoma, the typical imaging appearance would be a very hypovascular lesion. So again, if you do an arterial study and have that hypervascularity, you can think about pheochromocytomas. So that was that. And the last case that we discussed was an iatrogenic diaphragmatic and pleural injury due to PTBD. It can be seen in 0.5% of cases. And whenever you see pleural effusion, that should make you worried about a pleural injury. And in this case, what we did to confirm was we did a pleural aspirate, and that showed bile salt. So you saw there was a collection around the draining tube. So there's bile draining onto that and into the pleural cavity. So that was kind of a fistula between the bile ducts and the pleural cavity. So if you do a bile, if you see bile in the pleural fluid, that confirms that there's probably a fistula due to this injury. So those were my cases. Thank you everybody for joining me live. Thank you everyone who's watching this later. And if you're new here, make sure you check out our radiology resources on our website, radiogyan.com. If you register via email, you'll get an email for feedback. You can let us know how we did. Like the video if you liked it. If you didn't like it, you let us know in the comments how we can improve. And subscribe to the channel, like it, share it with your friends. That way, even your YouTube feed will improve and we'll get more relevant radiology videos in your YouTube. Thank you everyone for joining me. And even for those who are watching later, thank you. And I will see you guys in our next video. Bye-bye.